Good morning. My name is Alex Zlotta. I'm a uro-oncologist at the University of Toronto, working at Mount Sinai Hospital and Princess Margaret Cancer Center. The mainstay, the main treatment for non-muscle invasive bladder cancer is to perform a transurethral resection, basically to bring patients to the operating theater and then to literally endoscopically operate on tumors. Now, we all know that we live in times of budgetary constraints, and since at least a couple of decades, probably 3 decades, instead of having to operate for every single recurrence, in patients who were found with low-grade TA, thus the completely non-muscle invasive low-grade tumor, when these recurred, a new technique which has been called office fulguration has been introduced. Office fulguration is at the time of the flexible cystoscopy with a probe. You basically, when you scope the patient, you cauterize the tumor, especially when these are small tumors and not numerous, 2, 3 maximum. And urologists in the past have been fairly good at picking tumors which are low grade in patients who initially had low grade disease. The problem was that although this avoids for many patients to undergo surgery with the risk of anesthesia and the cost, it hasn't really caught in a fairly consistent fashion, maybe because one, there were no long-term data and that the technique was not super popular. Here in the study at the University Health Network, we reviewed the largest series to our knowledge, which is 270 patients with a follow-up of close to 10 years, so long follow-up. And we analyzed the results of a series of patients who initially started with a low-grade disease. And then when they had a recurrence that looked low-grade, had their tumor fulgurized rather than all the time being brought to the operating theater and treated with TURBT. And what the study showed was that the cancer-specific survival at 10 years was 100%. So that it was completely safe. It avoided at least 3 TURBTs compared to a group of patients where only TURBTs would have been performed. And it clearly, and we did this with a cost analysis in Ontario, saved up to $2 million in a series of only 270 patients. So you can imagine how that translates in terms of cost savings for many institutions and countries. And so the summary is that the patients with initial low-grade disease, where the tumor looks low-grade and it's small, and there's only 1 or 2 of these, we can show that the office fulguration in the office at the time of the cystoscopy provides exactly the same outcome, 100% survival, no oncological risk, and obviously less surgical problems, less anesthesia problems, and less costly. That's really the gist of the study. As we all know, non-muscle invasive bladder cancer is fraught with high risk of recurrence, and one would not be astonished that close to 50% of patients during follow-up had some kind of a recurrence. But as I said, compared to a group where all the recurrences would have required a surgery, half of those recurrences could perfectly and easily be managed with cauterization. But nevertheless, as you perfectly pointed out, we still are working on trying to decrease the recurrence rate of this disease, which is a real problem for patients. I think, honestly, at our center, it's actually fairly easy to organize. Many other centers, and Mark Soloway from Miami is on our paper because he has also pioneered this, this procedure, Harry Herr and Memorial in the 80s, 90s as well. So basically what you do is very simple. A patient shows up, he has a flexible cystoscopy, you scope him, he has a past history of non-muscle invasive low grade. The tumor looks small and looks non-muscle invasive low grade. At the time of the cystoscopy, you simply put a grounding pad, hook the patient to the electrocautery machine, and you pass through one of the channels of the scope a simple probe that actually then goes on top of the tumor. If you start at the top of the tumor where there are very few nerves, actually patients barely feel anything, and then you can bust and completely cauterize the entire tumor until it completely disappears. And so although some people have said it's difficult to organize, very respectfully, I'm a little bit at loss of understanding. You need the same equipment, simply an electrocautery machine, and a little bit of basic technical expertise, which is super, super, super easy to learn. The best candidates are patients who initially had a low-grade, superficial, non-muscle invasive bladder cancer, TA, and where the recurrence looks like TA without a positive cytology often. These are the best candidates because this addresses tumors at risk of recurring, but if tumors have a risk of progression, one has to be really more careful. But what our study at the end of the day showed was that in experienced centers, when people do this on a regular basis, surgeons are actually pretty reliable at picking up something that looks low grade and fulgurize, and the 100% of cancer-specific survival at 10 years speak for themselves that we basically did not misinterpret high-grade tumor and burn them and having exposed those patients to a risk of progression. There is one ongoing randomized trials where patients are either actively surveilled or they are fulgurized. And I think you're absolutely right that the outcome of this trial will probably guide further management. I think that fulguration at the present time is a very good compromise. About 40% of patients in our series still had intravesical treatment, but it's a good compromise when you see a small recurrence. To deal with the recurrence, it's possible that active surveillance on the long run will be equally effective, although it kind of counterintuitive to think that if you just follow and monitor rather than burn, results would be exactly the same. But as I said, the fulguration is an in-between tool, not bring patients to the surgery, not necessarily impose on intravesical treatment, whilst at the same time not simply monitoring things with sometimes even the anxiety of not having done something to those patients.